Hello everyone, this is Mrs. Korea. Welcome to week 6 lecture. We'll be discussing on nursing care of women during labor and birth, which will be the second stage, third stage and fourth stage of labor, and nursing care of women experiencing complications during labor and birth. We will start with second stage of labor. Second stage of labor starts with full dilatation of the cervix and ends with birth of infant. And there will be an urge to push or involuntary bearing down, and that indicates the second stage is going on now. And epidural analgesia can be given, and then they will not feel the urge to push, so the laboring down is used. So we need to tell them with each contraction to push because they don't feel the urge to push. And the research suggests that decrease in maternal fatigue and increase in fetal oxygenation when women delay pushing until they feel urge to push. So what happens sometimes, the women start pushing early and then they get tired, and there will be less time for the relaxation between the contractions, and there could be more chance for fetal hypoxia. So delay pushing until they feel the urge to push. There are two types of pushing: closed glottis pushing and open glottis pushing. In closed glottis pushing, the pushing is at full dilation regardless of the urge to push, and we need to discourage breath holding to avoid fetal hypoxia. And in open glottis pushing, otherwise called as involuntary pushing, is the recommended method of pushing, and we need to encourage release of air. Ask them to hold breath for 5 to 6 seconds during pushing and take several breaths between each bearing down. So this taking several breaths between each bearing down will facilitate maternal fetal circulation and gradual fetal descent. We need to encourage comfortable position. If they want to go on nature's position, that is fine. If they want to go on sideline, that is fine. So they can change their position in between. Some bodily preparations occurs for the birth of the baby. They are with maternal bearing down, bulging of perineum and rectum occurs, then flattening and thinning of the perineum can happen, increased bloody show, and labia begins to separate with each contraction. And how will you determine if the birth is imminent? The crowning happens, and that is, the fetal head is encircled by vaginal introitus, and the birth is imminent with this. And there will be burning sensation. You will see the mom screaming because of that burning. That is why we like to use the oil so that it is smoothens and less burning sensation with that use of oil. Then intense pressure in rectum is felt by the mother, and lacerations can occur with this. Lacerations can be divided into first degree, second degree, third degree, and fourth degree. I want you to read from the textbook. And this is the time they may do the episiotomy. There are two types of episiotomies. They are midline episiotomy and mediolateral episiotomy. Again, it is not always recommended to do an episiotomy. Some providers prefer for a natural tear than doing an episiotomy. Again, depending upon the condition of the patient and the gravity of the patient and the para of the patient. The cardinal movements of birth are descent, flexion, internal rotation, extension, restitution, external rotation, and expulsion. Please read this in detail from your textbook, and I will be explaining this during the simulation day. Umbilical cord clamping. There are some controversy regarding this, when and how to do it. There is a possibility of 50 to 100 ml blood flow from placenta to baby. And in tame babies, it can be delayed for 6 to 120 seconds if no issues. That helps in reducing the iron deficiency anemia. And the ACOG says there is insufficient evidence to support or refute this. So depending upon situation, if the baby is fine, there is no respiratory distress, no meconium aspiration, then we can delay it. And in preterm babies, evidence support for preterm babies who do not require resuscitation. And remember this, preterm babies who do not require resuscitation only. Delay for 50 to 120 seconds, which helps in improving circulatory and respiratory function and risk for intraventricular hemorrhage. But most of the time with preterm babies, you will see that there is respiratory distress. So we may not be able to do that delayed clamping, but if there is no issues, yes, we could do that and it is helpful. And concerns of delayed cord clamping are neonatal hypervolemia, polycythemia, neonatal hyperbilirubinemia requiring phototherapy, and maternal postpartum hemorrhage. And in my experience, I have seen neonatal hyperbilirubinemia requiring phototherapy because of delayed clamping, but it is not a major concern, it is manageable. And the nurse needs to inspect the cord after cutting for the presence of 2 arteries and 1 vein, and we may have to collect the cord blood samples for laboratory analysis like Combs, the type, and RH factor. Some prioritized nursing diagnoses for intrapartal patient are pain, knowledge deficit, anxiety, fatigue, risk for infection, and impaired fetal gas exchange. The third stage begins from birth of baby to complete delivery of placenta. The signs of placental separation are the uterus becomes spherical and small, and elevation of uterus in abdomen, lightening and protrusion of cord, and gush of blood from vagina. There are 2 mechanisms of the placenta expulsion. One is skulls. It is called shiny skulls, and here the fetal membrane comes out first. And in Duncan, it is placenta separates from inside and it may come out like from sideways. That is why it is called dirty Duncan. And please read from your text for more information. Nursing care during third stage of labor are observed for signs that placenta has separated, oxytocin medications to control blood loss. We need to examine the placental cotyledons to see that everything is intact. So if there is a missing part, that shows that there is retained placenta. And we need to offer emotional support, foster infant attachment. Immediate care of newborn involves airway, warmth, Praislov-Apgar score, which is very important. We have learned that in the first day of clinical, and we have a video posted, so please review that. And identification of newborn involves giving identification bands, which is matching to the mother, and also giving security tags, which I can show you in the clinical. They either attach it on the umbilical cord or on the foot, depending upon the hospital. So if a baby is near any of the doors will get automatically closed. Fourth stage of labor begins from delivery of placenta through 1 to 2 hours after birth. We need to monitor position and firmness of uterus, which is very important. And if you feel a boggy, soft uterus, which indicates the involution of the uterus is not happening, and it may be due to a uterine atony, and we need to report them immediately and initiate frontal massage. We will be discussing about postpartum hemorrhage in detail during simulation day. Nursing care during fourth stage of labor include assessment of the lochia and look for any excessive bleeding, vital signs and urine output, offer blankets for shivering patients. You will see this a lot of time. The patients are shivering, so we need to offer warm blankets, promote comfort, and facilitate attachment and breastfeeding. Nurses need to be alert for the risk signs. They are hypotension, tachycardia, excessive bleeding, and non-contracting uterus. If you see any of this, prompt reporting is necessary and we need to begin some interventions. Now we are going to discuss on women experiencing complications during labor. We will start with shoulder dystocia. The statistics says it is uncommon and it is 0.2% to 3% of all births. And I have seen a good number of shoulder dystocias in my entire career over 21 years. And the head is born, but the anterior shoulder cannot pass under the maternal pubic arch. And this happens mostly with maternal pelvic abnormalities, history of previous shoulder dystocia, obesity, diabetes, short stature, prolonged labor, post-date pregnancy, and fetal macrosomia. And I have seen the most common condition is fetal macrosomia causing shoulder dystocias. How to detect shoulder dystocia? We need to be alert to clinical indicators such as slowed labor progression and formation of a caput that increases in size. And when the fetal head emerges, the perineum, that is the crowning, occurs, it retracts instead of protruding with subsequent contractions. Normally, with each contractions, the fetal head should protrude, but in shoulder dystocia, the fetal head retracts. So it is called turtle sign. It is something like the turtle's head retracts as soon as they see a threat. So the turtle head goes back into the shell. So same way, the fetal head retracts instead of protruding. And complications, neonatal complications are birth asphyxia, damage to brachial plexus, and fracture of humerus or clavicle. Maternal complications of shoulder dystocia are blood loss from uterine atony or from rupture, lacerations, extension of episiotomy, rectovaginal fistula, symphyseal separation, and postpartum endometritis. A little bit about symphyseal separation. I had a patient recently had a suspected symphyseal separation. The signs and symptoms are a patient will have a difficulty in walking, climbing the stairs, putting on clothes, waddling gait. These patients complain of pain at the symphysis pubis and painful walking and climbing stairs, etc., and not at the perineum. It is a pain at the symphysis pubis. Just to give you some information on the clinical aspect of it. Then the management includes McRoberts maneuver, which is performed by the woman's thighs are sharply flexed on her abdomen to straighten the pelvic curve. And you may apply suprapubic pressure, and the suprapubic pressure is applied immediately above the maternal symphysis pubis to push the fetal anterior shoulder downward. So you want to get that anterior shoulder underneath the symphysis pubis so that we can deliver the anterior shoulder. Then maternal position change, like hands and knees, squatting, etc., to give more open areas and widen the pelvis. And use of fundal pressure is contraindicated in shoulder dystocia. Remember this, because if you apply more fundal pressure, that can cause more problems like uterine rupture, etc. Another complication is precipitate labor and birth. This is a rapid labor and with intense contractions. By definition, a precipitous labor lasts less than 3 hours from the beginning of contractions to birth. And in a nulliparous woman, it may go like 5 centimeters dilation per hour, and in a multiparous woman, by definition, 10 centimeter dilation per hour. The complications of precipitate labor are trauma to maternal tissue and fetus due to rapid descent. Hemorrhage may occur from uterine rupture and lacerations. Fetal hypoxia due to decreased periods of uterine relaxation between contractions. So the uterus don't get enough time to relax between the contractions. So that can lead to fetal hypoxia. Then intracranial hemorrhage related to rapid birth. Nursing considerations are careful examination of dilation and effacement, reassure women and support person, breathing to avoid pushing and prevent tearing, careful examination of maternal soft tissues and placenta. Umbilical cord prolapse. This is more a serious condition. The loop of umbilical cord slips down below the presenting part of the fetus, and it may be occult, that is hidden, and it can occur anytime during labor. The membranes may or may not have ruptured, and the cord lies beside the presenting part in the pelvic inlet. And in the complete cord prolapse, the cord descends into the vagina. And frank or visible cord prolapse commonly occurs immediately after rupture of membranes, and this occurs as the gravity washes the cord in front of the presenting part. The risk factors associated with umbilical cord prolapse are long umbilical cord, which is greater than 100 centimeters, malpresentations such as breech presentations, transverse lie, polyhydramnios, preterm or low birth weight infant, multiple gestation, and unengaged presenting part. Management of umbilical cord prolapse include if there is spontaneous rupture of membrane, bed rest is recommended till the head is engaged so that the cord will not descend underneath the presenting part. And if artificial rupture of membrane is performed, which is recommended only after the head is engaged to avoid cord prolapse. Monitor for fetal bradycardia and variable decelerations during contractions that may indicate a cord compression. Prolonged cord compression can lead to fetal hypoxia, and occlusion of blood flow more than 5 minutes can result in CNS damage and death of the baby. And another measure is manually lift the presenting part of the cord. Other management measures include modified SIMS, extreme Trendelenburg or knee chest positions, administer oxygen by face mask to improve fetal oxygenation, and if cord is protruding from vagina, do not try to push back into the vagina. Instead, you want to keep it moist by using saline compresses. And manually maintain pressure of the cord till C-section happens. So you will be putting hand into the vagina and try to push the presenting part of the cord and try to release the pressure. Nuchal cord. This is otherwise known as cord around the neck, which is very common. You may see cord around the neck once, a lot of time. I have seen 3 times and 4 times. And sometimes you may see tight nuchal cord too. And it is the nuchal cord rarely causes fetal hypoxia unless it is tight. And it occurs most often with long umbilical cord. And the tight nuchal cord, you may see variable deceleration in electronic fetal monitoring. The management is when head is born, gentle palpation to feel the cord and loosen and carefully slip over the head. And if it is too tight, you need to clamp the cord twice and cut between the clamps and unwound from around neck before the shoulders are delivered. Preterm labor and birth, the causes include premature rupture of membranes combined with cervical insufficiency. The management is bed rest, hydration, and tocolytic therapy for up to 48 hours to allow for administration of antenatal steroids for the fetal lung maturity. Nursing management of preterm labor and birth includes careful monitoring, which includes fetal heart rate monitoring, and identify and report symptoms suggestive of fetal hypoxia, assess psychological status, and provide emotional support to the mother and the partner. And that is the end of week 6 lecture, and thank you for listening.